how do you balance one life against another life?
Usually we don't listen to prioritization. We are quicker to say, well, this is a poor patient, we're on their side. Supply of healthcare is usually governed or limited by what the society, what a country can afford. We're probably approaching a point where our system will be too hard to finance.
I hear you, but like I don't want to deal with it because it's so sensitive. Or like,
that's
what it is?
That is what it is. Look at what was done in this other region 15 years ago and see if we can make something out of it to help you prioritize.
Yeah.
And great idea, but no, thanks.
Mikael Forss, welcome to the Go Beyond podcast.
Thank you very much, Josef.
We are super happy to have you here today because you have such an extensive experience, huge CV in healthcare in different areas. Among them, you worked at AstraZeneca before the merger you mentioned as well. Strategy, you said?
Strategy and finance.
And finance. Yeah. You worked as a deputy CEO at Karolinska.
Yes.
Which is, if I'm not wrong, according to Newsweek, if it was like last month or so, when they announced it's like the 7th best hospital in the world, something like that. Yeah,
it's a fantastic honor for them.
They continue to thrive in that aspect, and then also on the finance side of a university hospital in Uppsala.
That's correct.
Well. Yes. And much more in essence. But please, Mikael, before we jump into the very, very interesting subject that we're going to discuss today, which is about essentially the finances of healthcare, how we subsidize things, how we take care of healthcare from a financial perspective. But before we get into that, tell us a little bit about yourself before we jump into that topic.
Okay.
Yeah.
I'm a Swedish national. I moved to Stockholm when I was around 20 years old. Mm-hmm. I have a business and economics degree from the Stockholm School of Economics. I'm not a doctor.
But not a bad thing in any way.
I've had a keen interest in science ever since, all my life really. After a couple of years at McKinsey, I actually ended up at Astra, which was then a mid-sized Swedish pharmaceutical company back at the end of the 80s. And I was there. I think I started at the same year as Astra launched Losec, the then blockbuster drug for ulcer, etc. So I was there for the whole journey of Astra, moving from, let's say, $500 million turnover to $30 billion turnover when I left. So
and that was all because of you, right?
It was all because of a little bit me and a lot of Losec and a lot of great work by many people. And during those 20 years when I was there, and this was around the millennium shift, Astra and the British pharmaceutical company Zeneca, they merged. And I was had the privilege, I must really say that, to be chosen as the CEO's wingman, so to speak, by way of writing the reports and doing the numbers, etc., before we found a company which we ideally wanted to merge with, and that was Zeneca. So that was a highlight of my professional life, to be part of that big event or period, rather.
Yeah.
And then I continued working for AstraZeneca for another 8-10 years, and moved to the Swedish side, where I was the CFO of the marketing companies. So back then, that really triggered my interest in how do the customers view pharmaceuticals. I was exposed to health economics, which we'll talk about later, I know, and got to know doctors and others who were using drugs instead of being sort of a corporate head office person. And
sorry, like I know that this is now a completely different topic, but you mentioned like how the consumers view the drugs, right? And you learn about that. What's kind of the number one thing you learn from that? Because that's so interesting. I mean, drugs itself is such an interesting area, but like, well, what did you learn?
Well, the first thing that comes to mind is the difficulty of a pharmaceutical rep to get the attention of a doctor, right? And to do that, you really need to be very attuned with the fast pace of the everyday life in healthcare, and have something very relevant to say and to convey where the doctor really perceive and get that the drug is an important thing to help him or her in their work.
Got it.
So if you didn't have that, you would not get the attention for a very long period.
Makes sense.
Yeah.
makes a lot of sense. So yeah, the connection with the health professional and the doctors.
The connection with the health professional and having something relevant to show and something relevant and be good at explaining it.
Yeah. And sorry, I cut you off there. So from AstraZeneca.
After 21 years there, I thought maybe I should do something else in life. So through various ways, I got to the job as a deputy CEO of Karolinska University Hospital at a very interesting time, because Karolinska had financial problems. So my first task was to, through a pretty traditional savings efficiency program, get that in order. And unless you have your finances in order, nobody will pay too much attention on your great plans for quality improvements, etc. So this was an important thing to do for Karolinska. And then my second big responsibility there was that I, after hiring a finance director who could take that over, was to get prepared for moving into the new hospital called the New Karolinska, which opened in 2016. So I started a program office with a good project leaders, etc., to prepare for that.
And for our viewers, because we do have viewers from around the world and not only in Sweden, of course, like if you could just tell them a little bit, because it's going to make sense when we also dive into, the economic principles of healthcare. What kind of hospital is Karolinska? Like what is it? How big is it, etc.? Just to kind of get an understanding.
So Sweden is a country of 10 million or so people. And we have 7 university hospitals, teaching/university hospitals. And Karolinska is the largest and probably the internationally best known of those. And it has around, around 1,200 beds at a time. And around 16,000 employees at a time. So and 2 main locations in Stockholm, right? And building a new hospital was a big thing because the facilities were required, but also to signify a new era of innovation, quality improvement, great teaching, land winnings, etc. So I was there for 8 years, and then I moved on to. I was at the stage in life when I was able to choose a bit more what I wanted to do. So I started my own consulting company. So I've been doing both sort of senior advisory jobs or assignments, I should say, and I've also been doing shorter assignments as a CFO of, and as you mentioned in your introduction, I've been in Uppsala, both at the University Hospital and the region there, as it's called the administrative part of Sweden, where you run both hospitals and primary care. So I got a experience pretty recently, not only of hospitals, but also of how do you finance and manage hospitals and primary care, and the interlink between the two.
Oh, so it was a mix of primary care,
yes,
plus hospital, essentially.
In one of the jobs in Uppsala, that was, and the other job I had there was that was the CFO of the hospital alone.
Got it.
Yeah.
And before we jump into the juicy top, and I know, like, when people talk about like health economics and financial and healthcare, it might not sound that fun for some at least, but like I really do think it is, because in the end it's about, again, like how we treat people, what kind of treatments we can afford, what we cannot afford, what the flow of healthcare looks like, how we make it more cost efficient, so the quality also like there's so many aspects we're going to dive into. And then again, I mean, the money then also regulates the quality of life for that individual, essentially.
Absolutely.
Right? So
absolutely.
It's
very real.
It is very real, right?
Yeah.
So it's such an important topic. And again, before we dive into that, I just wanted to ask you, from Karolinska and in Uppsala as well, and when you were working with these systems and hospitals, what was the most difficult thing that you experienced? I mean, I'm sure there were a lot of challenges and so on, but you know, what was the most difficult thing that you experienced in that journey?
I think a university hospital like Karolinska is one of the more complex organizations that you can manage out of any. Yeah. And I think that depends. Why is that? Well, it's got to be excellent in healthcare provision for the patients. It's got to be excellent in the research for the future benefit of patients, and it's got to be excellent in teaching. And the professors and other great staff of a university hospital, they are also often asked to perform duties outside of the hospital, you know, being part of government commissions and maybe advisory boards of corporate medtech at pharmaceuticals. So that becomes very... if you're a doctor at the university hospitals, you have your time management is a complex task. Yeah. and then you got, I don't know how many doctors, 2,000 of them or whatever, and you need to find ways of managing, help them manage and get a system where everything fits together. So that's the complexity of that. And also from a senior management perspective, it's harder to motivate one of those great doctors, professors to do their job, because they got different arenas. Yeah, they got their science arena, you know, the respect and the in their scientific community. They got their, of course, their staff, and they got their students, and they got maybe other external stuff that they're doing. Yeah, yeah. So you, in a big corporate like AstraZeneca, you can drive towards maximizing profit at the end of the day. And university hospitals, you need to find ways of acknowledging the different goals of the corporate as well as of the individual, and make that fit into a context where you still produce and manage your resources effectively, which then at the end of the day translates into sound finances. Yeah. And I mean, we're already digging into the finances and the topics we're going to talk about, which is so interesting. And I think also for anyone who's listening in is that in regards to kind of the structure of this podcast, we're going to try to address, you know, the basics and the start, just for people to kind of get the kind of the one-on-one on what it is all about, and then dive a little bit more into, you know, the different costs of healthcare, the systems, and in the end, I think, which we're probably not going to be able to answer, you and I. I mean, we can always, you know, wander around the subject, but to really ask these, I guess, a very controversial question as well around, you know, what the price of life is, essentially, you know, where we spend, who we spend it on, because in the end, when you do spend money on someone, that means that money maybe is not spent on someone else, perhaps that is in need of treatment and so on. And that is a very, very controversial, right? And an ethical question as well. Absolutely.
So let's start with the basics,
Yes.
right? How do basic economic principles apply to the healthcare industry? Let's start with that.
Yeah. The very first thing I like to say is that, I think if you take the word economy or finance, it comes from the origin of that word in Greek or whatever it is. It means that a way of managing resources, scarce resources, in a responsible way. So that's what it's about. It's not about money as such. It's about
the scarcity
of time and scarcity of money, and to put that into the best possible use, really. So that's the purpose of economics and finance in any context, really.
Yeah.
And when it comes to markets, supply and demand, most of us are familiar with supply and demand, right?
Yeah.
So when it comes to healthcare, the supply of healthcare is usually governed or limited by what a country can afford. So that's we often express the amount of money spent on healthcare as a percent of gross domestic product.
Mm-hmm.
Yeah. So that's what our taxes, and since in most countries healthcare systems are financed by taxes, that puts a limit, right?
Yeah.
So that's on the supply side. How much can that buy by way of hospitals and doctors and nurses?
Yeah.
On the demand side, since most of us don't pay for healthcare out of our own pocket, at least not in Europe and so forth, our demand for healthcare is almost infinite, or at least it's very price insensitive.
Mm-hmm.
So right there, you got a problem of matching what the country and society can supply with the demands, and usually it's never enough healthcare in order to meet our demands.
So it's like an unlimited demand, like
demand, or a much higher demand than what.
And limited resources, actually.
But very limited resources.
Limited, yeah. But then interesting that you mentioned that, Mikael, is, you mentioned, for example, here in Sweden or in Europe, we don't pay that much out of pocket. But now in comparison, then, you look at, for example, we do have operations, for example, in Kenya and other parts of the world, and there you have an out-of-pocket spend up to 40-50% of healthcare and the healthcare spend. Does that, I guess, shift the dynamics of supply and demand, or is it more about, because again, we mentioned this unlimited kind of approach here in Sweden, but limited resources, or is it, do you think, the same in that regard?
I think you get closer to what is a real equilibrium in maybe Kenya or somewhere than you do here, because you, with a society which maybe needs to be more careful about its scarce resources, you need to think harder about where you spend the money.
Yeah.
And when you pay as much as you mentioned out of your own pocket, you also need to think how much do I treasure and what value do I put to my own health in relation to other things that I need to pay for.
Yeah.
And I think for most of us individuals, I guess anyway, we're willing to pay quite a bit for our own and our family's health. And from a society point, and the way that translates to Sweden, for instance, is that the willingness to pay taxes is quite high here. We pay tax. We know that we get basically free healthcare of great quality here, and we appreciate it. So the willingness to pay is, in an indirect way, is there.
Is what you're saying also that the way it works in Sweden? Because it was interesting now when you mentioned, for example, now Kenya or maybe the US or other part, not necessarily where you don't have any subsidization from government, but maybe there's a bit less, right? But you mentioned that you get closer to this kind of equilibrium and managing your resources. So am I wrong in saying, and correct me if I'm wrong here, am I wrong in saying that it's not always, the perfect way of doing things by having free healthcare, like from this kind of equilibrium perspective, from managing resources, or what do you think from that perspective?
I don't think it's a perfect way, and I think, but it's very hard to come up with a different way, particularly when you've built up a society like we have for so many years.
Yeah.
But we'll when we talk about I think we're approaching that what we can provide through tax finance healthcare will not be enough for the technological possibilities and for the expectations of the population. Yeah. So we're probably approaching a point where our system will be too hard to finance here.
Yeah. And then,
what we'll do is another story. We'll get to that.
We'll get to that. Yeah, exactly. But like, where, what do you sacrifice? And like, in a system like that, as you said, the resources are limited.
Yeah, but I think there are countries that are better than Sweden in managing that already. So I think there's hope that one can find models.
Also. That's fun. So we'll get back to that.
We'll get back to that. Okay, that's good. A cliffhanger.
No, that's a cliffhanger. Okay, the country that's better than Sweden in that regard. I'm sure there are many. So then we covered some of the economic principles in essence. Can you then compare, I guess now getting back to that, is the cost effectiveness of different global healthcare system? This is sort of what we were discussing, right? We're discussing about the limited resources and the demand as well, and how that combines. But now, behind all of that is now also coming into the subject of the resources themselves, because you do have costs in different categories of healthcare and delivering that service, et cetera, and medication. There are many, many things that essentially contributes to the cost going up, right? So what do you think are some of the primary factors that are driving up the healthcare costs, like from a worldwide perspective, right? What's driving up the cost of healthcare?
I think the things I'm going to say are probably familiar to many of our listeners, but
sure.
The aging population for one. And great healthcare produces older populations. But at the end of our lives, we spend. That's when we demand and consume a lot of healthcare. So that's one of the factors. I think expectations on the part of us individuals to really get the benefits of the new technologies and new pharmaceuticals is also a driving force, and companies behind those who want to drive demand, right? I think there are some lifestyle aspects as well. We don't always want to change our lifestyle to eat less or to live in a different way. We'd rather, if there are drugs which help us go down in weight, for instance, we'd rather take those than to exercise. At least some of us.
Like the Ozempic, for example. Or
exactly.
Yeah.
And I think technology is a very legitimate driver of increasing healthcare costs in a way. It's both a driver of increased cost because there's a wider, bigger menu, so to speak, right? But also technology helps us reduce costs. There are a lot of examples where we can look back, for instance, that are the number of days you need to spend in a hospital bed on average has gone down so much, and that's thanks to great advances in day surgery, etc., right?
Yeah.
So that's on the other side of the equation. But there are, let's see, what else is there to drive increases in demand? I think to some extent it is the systems where healthcare is regarded as a free commodity as well, right? So you
and it seems like, from what you're saying, it's kind of like a double-edged sword where healthcare and better healthcare leads to now an aging population and people living longer, which is hopefully a good thing, and then you get more time and enjoying life. But also at the same time, you said kind of the menu of products also start increasing, and I guess there's never a limit to healthcare because essentially, or we can always argue around this. I think most people would probably, if quality life years can be, something that the healthcare can deliver to you, would probably not say no to that. I mean, maybe I get another year, I get another year with our family, and I'm healthy, and I'm all that. I mean, that's fantastic, right? But again, the menu would increase, there are more products, more costs. Now, how do you think we keep some of those kind of costs down? Because you also mentioned technology can help to reduce those costs, right? And then I am guessing what you perhaps are alluding to a little bit is now also looking at the preventative side of healthcare.
Absolutely.
How does that contribute to the whole kind of cost economics aspect of healthcare versus, preventive versus reactive care? How does that play a role?
Yeah. Before I get to that, one thing I forgot to mention, I think, when you asked about what's driving increases in healthcare cost, I think bureaucracy and complexity of our healthcare system is also driving costs in a horrible way, really. There are so many insurance companies and people who need to track and manage quality and follow up, etc. That's taking away a lot of the productive time to treat patients. And so that complexity of healthcare systems is driving cost as well.
That's interesting. Okay, so let's
forget your other question.
No, because that's really interesting. So let's touch on the preventative versus reactive, but I would love to hear your thoughts then on the bureaucracy and the complexity. How do you now, how do you try to do something about that as well? But
the preventative care is a great thing and a great subject, and I think if you take Sweden here, which is the area which are the areas where we've been successful? Well, dental care. We've been we all very obediently go to our dentist to have the annual checkup. We had the fluorine mouthwash when I grew up, for instance, right, as a mandatory thing at school. We have the screening programs for certain cancers, for instance, which are cover all population or certain ages or genders, which I think are great preventative programs. We have vaccine programs, which just take the COVID situation where, society really managed to make us comply with most of us, at least here in Sweden, we got the vaccine, right? So those are the successful examples. But whereas other things are very hard to make us do from a preventative point of view. So there is a behavioral side where how can you manage and have us as individuals do the right things from a preventative point of view.
Yeah.
But there are other examples than the three that I gave too. Take high blood pressure. No symptoms for the most part, and still many of us take those drugs, and that's a big population health factor, right?
Yeah. And is that also now, because obviously there's a lot of trends. There's always trends and differences, but in healthcare specifically, right? And there's so many fitness, workout trends that all of a sudden now a lot of the responsibility is falling on the individual, right? To take care of themselves, what to eat and how to exercise and do this and weight loss, all of these things, right? And this is now, I guess, at least from my perspective, where it also gets a bit convoluted, which is, you mentioned that there's an unlimited kind of demand for healthcare. And then, at least from my perspective, is that this is now kind of also growing in the other direction, that it's not only about, an aging population, but it's also a younger population that are using everything from healthcare apps to whatever it might be, to your Apple smartwatch and tracking your health and all of these aspects. And you're starting to learn more and more about your body. And then where does the responsibility kind of fall, as well as where does the cost land? Is it, who should pay for it,
So it's such an interesting area to discuss. But I think I remember I was giving some talk while at Karolinska the same day as the Apple Watch was launched.
When was this? This was
I think it probably 2015.
2015. Something
14,
like that.
Something like that.
Probably something.
And I remember saying, as an intro that this might be an important day because this is going to influence our behavior, how we measure some of our health parameters ourselves.
Yeah.
And I guess that is the case. So in my view, we measure a bit too much, and we worry about a bit too much instead of just trusting that our feel-good factor is enough to, to exercise or whatever. And to the extent that means that we also worry about our health, and we want to go and see our doctor because we see some small signals or that something might be wrong, that's causing an unnecessary demand of healthcare.
Yeah.
And we've seen that in so that's it's a two-edged sword as well, right?
Yeah.
We wouldn't want to do without it. It's a great thing that many of us pay attention to our health, and to the extent that we get motivated by measuring, that's also a good thing. But to the extent that this drives unnecessary healthcare demand in a situation where we, as we said initially at this discussion, the supply of healthcare is limited.
Yeah, exactly.
So is it responsible to ask to go and see your doctor just because you have a vague suspicion of something being wrong?
No, exactly. And I guess
what's your view?
From my perspective, it's very interesting because obviously there is some value in what it does, right? You get insight, you learn about your body, you see, hopefully with the data, you're also able to prevent certain diseases even in the future. This is what we are doing at Bionate. So at our company, where we are investing a lot into our AI. We're investing into the app to track the health behavior of the user. To now also look at how can we actually prevent you from becoming sick in the first place? Are there certain behavior we can avoid? Are there certain things? And this is gonna get crazier with time. We're gonna have, let's say in maybe 10 or 20 years, we're going to be able to read this from your lab values and even your genetics, and we can give you, a certain, unfortunately, I would say, we would even be able to give you this is how long you would live, this is what you would do, this is what you need to do. And again, it's a double-edged sword because it creates it stirs up a lot of worry. Maybe that isn't really that helpful sometimes.
No.
I don't want to know this, right? Maybe some people do, maybe some people don't, and that's a difficult thing to balance.
But to the extent that we can diagnose or predict in a better way, not only who needs healthcare, also who does not need it.
Exactly.
That's, I think, is the in a way the solution. I hope it is anyway. That it helps you differentiate healthcare and lifestyles maybe as well a bit, depending on your dispositions.
No, and that's where technology comes in, right?
That's
you
really
need to automate some of those processes so you're not overburdening the healthcare system.
That's right. And maybe, maybe my dental health is so great that I shouldn't go to an annual checkup. It should maybe be every third year. Yeah. Just to take a very simple example of a very traditional, and I never heard my dentist. It's just a routine thing, once a year. Who came up with that anyway? It's pretty arbitrary.
It's interesting. No, and then again, like coming back to the aspect of that behavior, and like some behaviors are hard to control as well, but others are very successful, like the dental example. I want to jump.
So it is, it is on balance. Preventative healthcare, maybe in a more differentiated and responsible way, must be a great thing. That's absolutely. I think that's the bottom line anyway.
Absolutely, yeah. We just need to appropriate it in the right way. In the end, digging even deeper into the healthcare costs, and you mentioned that I asked you like what's the biggest contributor to like high healthcare costs, and you mentioned that like an aging population is one of that. Like, but specifically. Like if you would go in and you look at your financial report and you're looking at Karolinska and other things, right? And you're looking at like there's a lot of cost here. What would that be for a hospital? Like, and again, maybe that relates to the aging population, but like, how would that look?
I understand.
Like? Yeah.
So from a sort of more static point of view,
exactly.
If you look at the whole, Sweden is where I know the numbers relatively well. The hospital care is probably around 50% or something, right, of the healthcare bill, and primary care maybe only. I'm making up the numbers a bit now, but say 15% maybe, right?
Wow,
so the secondary and tertiary care is really where the big part of the bill is. Yeah.
So this is when people are admitted to like
when
hospital.
People are admitted to hospital. If you just look at what was my budget at Karolinska, and you add up the budgets for all hospitals in Sweden, you would end up at a 50% of the healthcare bill.
Wow.
So that's one perspective, right? And so investing in preventative care and in the primary care is to the extent that you can take care of patients there instead of having them go to the emergency clinic, particularly, right? Is a great investment to make. The return on that investment to spend a bit more there and avoid having to gear up in the more hospital beds, etc. To the extent that is possible, that's a great thing. Or self-monitoring of disease, etc. So I have a lot to say about doing things. If you call it downstream, I suppose you call it, right? Yeah.
And like, is that coming back to the fact we were talking about prevention and other things? Because like 50% versus 15% primary care. Shouldn't that be like the other way around? In the best case scenario, right? Like where more is actually being spent on primary care.
That's my view. Yeah, at least more than today. Because it goes without saying that advanced equipment in a hospital does cost a lot, and specialized taking care of very rare diseases or advanced cancer treatment, etc. We want that in society too. So but anyway, some shift. So that's one perspective. The other perspective is if you look at disease, right? The chronic diseases like diabetes, etc. I forgot the number now, but they account for a lot of the resources in healthcare. right?
Absolutely.
And in terms of and the third perspective is age. I ran a project in Uppsala where I worked most recently, actually, to look at the healthcare that is used, so to speak, by 75-year-old and older people. And the conclusion was that, of course, as you would expect, that a big part of the resources is used both in primary care and the hospital care and in the what we call omsorg in Swedish, the looking after the elderly at their homes, etc., and nursing homes.
Got it.
And so that's elderly, chronic disease, hospitals. Those are where I'd look to get efficiencies.
The big one, so to say. Like, so in when you look at, let's say, that 50% hospital spend, right? Admissions, etc. Because again, there's many different things that you can spend money on, right? You have your personnel, everything from the diagnostics, maybe x-rays, maybe other things. Like, how would you kind of divide, like, what's the biggest category within that? Like, is it personnel? It's
absolutely personnel. So let's say staff. Again, take these numbers with a grain of salt, because I don't have them in front of me now. But like, say 70% is probably staff costs. 10% at the most is pharmaceuticals. And then you get a lot of, then you got facilities, rent and depreciation of equipment, etc., which costs a lot. So facilities cost quite a lot.
Okay, so that's also a big part of the.
Of the remaining 30% or 20%, if you'd maybe that's facilities and machinery and equipment and facilities.
Got it. Wow.
So you'd. It's a people.
It is. It's
business.
A people business in the end. And then it's, I guess, and we can come back to that, is then in how do you make that more efficient as well? Because I mean, you do want people in healthcare, but you don't necessarily want them to spend time on unnecessary things, as you were saying, like administration perhaps, or bureaucracy and other aspects, right? Which I know is like a massive headache, for example, for doctors in the U.S. in regards to like an insurance perspective and diagnostics and waste of time, right?
Yes,
which you could actually been spending on a patient in the end.
And even the quality follow-up, where you're required to do many things because of regulatory reasons and those sort of procedures. I think I'd be interested in what you as a doctor think there, but my perspective would be that a lot of that gives a false sense of certainty and safety when you do a lot of recordings, and at the same time maybe you think that you've done the job just by following a administrative procedure whereby you record different things in the journal, etc., and maybe the alternative cost of that, so to speak, is that you don't have the time to see another patient.
That's the thing, right? And hopefully again, where technology could help us, right? Because administration is at least I think in everyone's view, that's the last thing a health professional should be spending their time on. Like it's the patient and the treatment. Like that's the key focus. And now that we talked a little bit about, I mentioned U.S. doctors and insurance, because obviously health insurance and coverage plays a role in financials and economics. However, maybe to some extent, or actually to a large extent, it plays a much bigger role in countries maybe where you have less subsidization from government and people have to maybe spend more out of pocket, etc. So how do you think health insurance and health insurers affect, overall healthcare spend? What's their role in this big game of healthcare?
Well, that's pretty country specific in a way, right?
Yeah.
So if we take the country which has a most advanced system there, I think, and a good system is the Netherlands, where everyone is required to pay for their health insurance, which is heavily subsidized. But so the government pays for the healthcare, but I have a responsibility to sign up for an insurance. And there are 7, I think, national insurance companies in the Netherlands, and I can choose who I sign up with. So there's a competition among those insurers. They, in turn, procure, buy health care services from hospitals and doctors, etc. So they also. So and there is a competition there, of course, to among healthcare providers to get procured by the insurance companies. You guarantee a basic, which is a high basic level of coverage for every individual. You have a competition between insurance companies, and you have a competition between healthcare providers who want to get, purchased, procured by the insurers, and I think this is a pretty clever system. And if you look at the Netherlands, they got one of the top class healthcare systems in the world, both by way of how much it costs and by way of the quality results that it produces.
First of all, I had no idea. That was very interesting. Is this the cliffhanger country we were talking about earlier?
This is a cliffhanger country. And then I could talk about the US and Sweden as well, and to some extent the UK, where there are differently designed insurance systems which are not as efficient, I think. Because
I think one of the countries that are like on top of mind whenever you talk about health insurance is like the US.
Yes.
And not necessarily because it's the best way of doing things. I honestly, you know better than me. But then in comparison, because what you mentioned about the Netherlands was really interesting. So what you're saying that essentially government requires you to sign up for an insurance, but they subsidize it. So they
subsidize it heavily.
So you pay like a small part of the premium.
A small part of the premium.
Okay.
And you don't differentiate if you're in a bad, so to speak, socioeconomic area. You don't pay more because of the risk of your getting sick is higher.
Okay.
So it's also and every health insurance company is required to accept anyone who wants to sign up.
And then I guess there's competition among insurers as well to be subsidized, or I guess they apply of some sort to, or how does that work? Like,
well, to get the highest volume of people who sign up for them, right? And since they got a pretty comprehensive healthcare underneath them, they can actually balance primary care and hospital care in a way if they deem that as a good way to be more efficient. So they get more money, bigger profit if they would if they manage their population, their lives.
Got it. So like the insurance companies don't necessarily they don't have to be like approved by government or anything.
They do. I think there's a big regulatory side of that, which I don't know enough about.
No, of course. But then coming back to the fact of the U.S. then, if you compare it to the U.S. system, so how does that differ in that regard?
The first big difference is that the U.S. is not a comprehensive system. Everyone is not covered. As we know in the U.S., even though. I think those who've studied different healthcare systems and one of the contributors to an effective healthcare system is that there is a full population coverage. Because then you don't get the people who are, for I think obvious reasons, right? And then, so that's one reason. And the other reason is that there are private and most, the Dutch insurance companies are not for, they're for profit, but they are like foundations, so they reinvest their profits. There are not shareholders who want the dividends. Okay. So in the US, there are both you got the foundation type where you, same as in Holland, where you reinvest, but you also got those who want to pay dividends, right?
Yeah.
So there is a maybe not always healthy profit interest.
Yeah.
Then you got very. I mean, since the U.S. is such a big country, you don't have, and there is a pretty big mobility of people, and you got a very fragmented managed care market. Those providers, or call them insurance companies, they're called managed care or HMOs, usually, right? So if you are an HMO, or it may be hard to keep your customers from one year to another, so to speak.
Mm-hmm.
So that's also provides some instability for them, I think.
Yeah.
Although some of them, Kaiser Permanente is known to many people, I think, right? They got a very large presence, and they got a very comprehensive system. And I think they also are very efficient and appreciated. So, but less even quality of insurance companies. That's what, and less even quality of healthcare providers as well.
Got it. Do you because one of the challenges as well when you do have, let's say, health covers or premiums and whatever it is, and at least again, like in my experience working within this field, is when you have an insurance company and you have a healthcare provider that is now covered under that insurer, right? What seems to happen a lot of times, again, I have no experience from the Netherlands, is that people do come in with their cover, they have a premium, and this now leads to the healthcare provider looking at, because they also want to look at their revenue and cost, and they want to make money, they want to be profitable, etc., as an organization, but then they see this patient coming in, and then, oh, you're covered, right? You have an insurance cover, so that means there's whatever guaranteed money, if you want to put that in like that. That when I diagnose you, maybe I do another lab test, I prescribe an additional medicine or medication because, hey, I know that I can earn money on this patient. How do they avoid, number one, do you think that is an issue? Number two, how do they now, coming back to the Netherlands example, how do you avoid that problem, I guess? Because if all providers do this, unfortunately, that will drive up costs, right, in the end, and then premiums will increase, and then all of this kind of becomes a vicious cycle. So yeah, just kind of handing it over to you and commenting on that.
In the US, is there a system which sort of promotes taking another test just because you can afford it? That was one of the things.
Yeah, I don't think it's not like that there's there's essentially incentive, because again, if you're a business and you know that you can earn money on something and that there are certain costs that are covered and will be covered if you do the proper reporting. And this is not only like the US, like we're talking in Kenya, in Africa, and other countries where you have health insurance, because again, like this customer, they have a cover. So I know that as long as I'm not going like off the charts with the diagnoses or anything, I can still kind of motivate. Maybe I do another hemoglobin test. Maybe I do another glucose test. Maybe I send, a medication that's maybe a little bit more expensive, and I add 2 to them just to make sure. Maybe it's like a painkiller of sorts, like things that are not necessary a lot of the times, and unfortunately unnecessarily driving up the cost of the premiums, because for the insurer, well, we want to stay profitable, right? And all of a sudden we're paying more and more for our patients. So that kind of relationship between insurer and provider.
I think if you are General Motors and you want to procure a health insurance for all your employees, your very large employer.
Yeah.
It's competitive in a similar way as it is in the Netherlands, and there's some sort of capitation that every individual you pay so much, and then the insurer will need to pay the doctors and hospitals, etc., and they will put some pressure on them not to do the unnecessary stuff, because then they will have less profit margin.
Mm-hmm. Mm-hmm.
So if there is a capitation system, I think that probably drives the right behavior. It could also work the other way around, although I don't think it does so in the US, but in Sweden it sometimes does in primary care. You get a capitation and you can't afford all the necessary treatment. But anyway, going back to the US, I think that's so that's probably a good example of. And then you got Medicare or Medicaid, where the programs for the not well-to-dos. I think the management of Medicaid, they do very responsible investigations of health economics, etc., where they before they put a cap on what is spent per life.
Yeah.
So then why does the US have so high healthcare costs? I think the legalistic society that they are, that's even though what I just said, one of the reasons you want to do another test is probably that you want to say that I did all the right things in a legal way, so no one can sue me if the patient, if I missed something. Or you need your own insurance to should someone sue you.
Yeah.
And then you got the that's as far as it's not a good answer of why the insurance system is not as good as it ought to be, really.
Yeah.
Because with what I said, that ought to work pretty well in a way, right? So, but then there are uninsured part of the population where you need to, which means that those people, in one way they don't cost anything, but on the other hand they cost anyway by way of, indirect costs for health. Yeah,
of course. Yeah, I mean, a healthy population in general, at least from a kind of societal perspective and from a country perspective, that's what you want, right? It's everything from labor to health to engagement. I mean, all of it. Like, it's always positive. Yeah. But I mean, I guess
bureaucracy costs, if I may interject, in the US, I think are higher than in most places because of all the form filling, and I got friends there who just say it's just a nightmare when you want to file for your health care costs or what have you. So I think that's an even bigger part there than it is in most countries.
The thing I wanted to kind of put it into light to in comparison to maybe Sweden and other systems where we talked about, or you mentioned, there's an unlimited demand, right? Mm-hmm. And then you have like a limited amount of resources. Because what's interesting, and from what I've seen is, and there's... I don't know how much of this is true now when you go to hospital specific or primary care specific, but it's let's put the two in comparison. You go to a doctor in Sweden, it's much harder to push them and motivate them to do certain lab tests because you know that you have a certain budget to work within, right? Yeah. And maybe some of them are subsidized, some of them are not. And then you have maybe a controller, whatever it is, making sure that you don't spend money outside your budget and you're managing that. And again, like all of a sudden that relationship shifts when you go to this insurance provider kind of relationship, because again, you know that your budget or whatever you're earning, that's going to come from that insurer, right? When you do those tests. So instead, there is incentive to like, let's do an additional 2 tests or something. So it's kind of it's a twisted way. And that's why I want to go back to the Netherlands
and more private payers as well.
Exactly.
That's another thing that is different in the Netherlands to the US to Sweden. There are many more people who pay, I guess, a hugely expensive healthcare insurance just because they can, and then they can ask for whatever
they want.
Yeah.
And I guess that's the fine balance, right? Between it's not, and it's a complex problem. Like, it's not just one aspect.
Again, in the Netherlands, they're clever there as well, because the basic level is pretty high, but you can choose to pay an add-on to get extra healthcare, so to speak.
Okay.
I don't know
to get the premium kind of part of the
and how they balance that in a democratic, equalistic society. I don't know, but anyway, I've interrupted you. Sorry.
No, absolutely not. This and like the last kind of, because what I want to dive into is, because we talked about the costs. We're going to get to this kind of value of life, price of life question in the end. Before we jump into that, how does pharmaceutical pricing, because I mean, you've worked with Astra and others, like, how does pharmaceutical pricing play a role in healthcare economics? Because I guess it has because we've talked about We've talked about personnel, we've talked about facilities, we've talked about diagnostics, but now like medication, right?
Yeah.
How big of a role does that play?
I think, if I were a doctor, I would think that, pharmaceutical is the primary tool in my toolbox in a way, right? It's or at least one of them. So the advances that society and science has made in pharmaceuticals are fantastic. If you look at 100 years ago, we didn't have too many pharmaceuticals. Today we have a wealth of different things we can do. When it comes to the payer perspective on pharmaceuticals, I think, if I take Sweden as an example, I think it's a best developed area for applying health economics to and balancing that with the price. So before a reimbursed price is approved, which it is on a national level here, that's preceded by a health economic evaluation, whereby one compares it with the existing best treatment and see and makes a decision on pricing where a quality, the difference between the existing treatment needs to be big enough to justify the higher price.
So essentially the pricing is approved on a national level.
Pricing is approved on a national level, and it's based on a health economic evaluation.
Is that the same in other countries as well, or does it?
It's the same in the Netherlands, in the UK, in the US. At least it's true for the Medicaid board.
Yeah,
but probably not everywhere else.
Okay.
So I think, pharmaceuticals are studied in a better way than other treatments when it comes to saying how much can they cost.
Yeah.
And when it comes to, when you look back, you heard me mention that I was there for the journey which started with Losec at Astra. I mean, that's probably, even those who have studied this, I think they would single out Losec or proton pump inhibitors as one of the key innovations in the last 50 years in pharmaceuticals, because it did so much to alter treatment from surgery to medication or curing ulcerous disease, preventing it, so that helped reduce the cost to society of gastric disorders.
So it was worth the investment in the end, right?
It was worth the investment big time.
Yeah.
Whereas most pharmaceuticals aren't that way. They might represent, 10% improvements on compared to existing therapy. Then it becomes harder to determine should you do this.
Yeah.
And then you got cancer treatments where you maybe add another half year of somebody's life expectancy, but that's worth a lot to that individual, and society is also willing to pay quite a bit for it.
And this is so interesting because it takes us into, I guess, our next topic in a sense, which is the concept of like a value of a statistical life.
Yeah.
Like and this is, and maybe there are other terms for this in other areas, but this is now something used by economists to guide policy decisions as well, and how healthcare systems, how it should work, how similar metrics should be analyzed. Because in the end, like if we come down to it, we've now been discussing the hospitals and primary care and how prevention plays a role. We've discussed pharmaceuticals. We've discussed health insurance. How healthcare professionals, their salaries cost money. I mean, everything costs money, right? And able to kind of service the patients. In the end, healthcare is about healthcare. It's taking care of people. And that's a very sensitive thing, right? Because, again, we know how sensitive the discussion about even like just healthcare data is, right? Like data is a sensitive subject, and your health data is very, very like important. And now we are talking about data and money that gives you information about certain metrics in society to now lead you in policy-making decisions to make sure that you are progressing in the best way possible. And now this means that you are, in one way or the other, prioritizing certain groups maybe over others. I'm not saying exactly who or which or whatever it is, but in the end, there is unlimited demand, I think you put it perfectly, and limited resources. How do we decide who gets what in the end? Because it's a very ethical question as well. Yeah.
And I think that's a question which has yet to find its answer, right? But the as far as I know, the menu, as we put it, of it's very hard to take away any dish from the menu. But when it comes, but what we're better at is, as a society, is to evaluate if we should put a new dish on the menu. And that's where the health economic evaluation comes into play. And it may be, also to replace one item on the menu with another. So incremental changes, or we're good at evaluating. And the way we do that is by health economics, usually, and putting a quality adjusted life year is the term, which is
the QALY, or QALY. Yeah, exactly. Yeah.
So maybe we want to delve into that, but I think that I've yet to find examples where healthcare system, whether it be a regional one or a hospital or a country, has said, well, we can't afford all this. Let's now rebalance this. Is it really adequate to give very old people certain surgical treatments because this is a very controversial question, but that's you recognize it, I'm sure. Is premature care of the too early born babies, is that worth its while? Are some very narrowly defined diseases, rare diseases, can we afford those, etc.? Those questions, the politicians and others are not able to rebalance the mix of healthcare on their menus.
And that's such an interesting thing, because you're talking about decisions that decide whether certain groups are getting money, which can now lead to certain groups also perhaps living longer or not living longer, or like, again, coming to the Cali and all of that. So let's put you in that scenario. Like, you're a politician and you're making these decisions. How the heck are you going to make a decision? Like, how do you balance, essentially, like, how do you balance one life against another life? And then we'll also come to the aspect of the doctor, right, and the health professional. But like, I guess from a policy and politician perspective, it has a very, very high impact, right, of where the money goes. Again, you know more than me here, so yeah.
But I think there is no common currency for comparing different treatments and lives. Well, there are for incremental decisions, existing treatment versus new treatment.
Yeah.
But when it comes to taking every need that there is and saying put the priority to different patient groups, I think nobody's been able to really do that in a way which is theoretically sound, let alone ethically accepted.
Yeah,
I know an example. I know two examples in Sweden. I think 10-15 years ago there was one of the regions in Östergötland, right, who tried to do this and presented their politicians with some sort of priority system. But at the end of the day, the politicians said, no, we're not prepared to do this. And when I was in Uppsala, I was also saying to the politicians there, why don't we look at what was done in this other region 15 years ago and see if we can make something out of it to
priority
to help you prioritize.
Yeah.
And great idea, but no thanks. So
but
that's
but that's such an interesting thing, because it's like, I hear you, but like, I don't want to deal with it because it's so sensitive, or like, that's what it is.
That is what it is, because as you then have to, if we just put ourselves into their perspectives, right? They would then have to meet the press. As soon as you take away something, there is a patient group who usually is quite vocal, who will go to the new press, who will complain, and it becomes an impossible battle to win and explain why you are taking away something. Usually we don't listen to prioritization way of reasoning when we, as TV viewers or as reading our newspapers, we are quicker to say, well, this is a poor patient, we're on their side, against the politician who decided to not give them a certain treatment. So I think that's the mechanism.
But isn't that like, again, it's like you're blindfolded and like, because if there's no prioritization, and just help me understand maybe a little bit about what this prioritization is. But again, it sounds like you're putting different priorities to maybe different groups or whatever.
But some point system. I don't know enough about it actually, but
but then in a way, wouldn't that kind of system make it easier for the health professionals to understand where money should be spent, or like how they should prioritize the patients? Because in the end, and I guess the prioritization happens either way, right? I mean, it's going to happen on the floor.
Exactly.
It's going to happen in one way or the other. Money's going to be spent on certain groups or on certain things, right?
I think, I've thought about this a lot over the years, and in a way, I think the good thing is that organically we got a health system which is probably pretty well balanced anyway.
Yes.
And why is that? I think it's because of the healthcare professions who have made good decisions on how to prioritize when they need to prioritize you have a lot of personal experience of emergency type of situations where you had to make this decisions on who to treat first or etc. And I think that's the best. Probably why we still have a pretty well balanced healthcare system, because the priorities have grown over time.
Yeah.
And when it comes to adoption of new technology, one of my best friends from childhood, who's doctor, I talked to him the other week about some treatment which concerned me personally. I said, well, if the non-surgical treatment had been the right thing to do, the profession would have jumped to it. That's how it works, Mikael. Since it hasn't, the surgery is probably the preferred treatment. So I'm a bit optimistic anyway that we have the sort of system that we have is pretty well balanced anyway. And the complexity of doing this in a sort of planned way, maybe it's an insurmountable task. It goes beyond what we're able to measure and quantify.
Yeah. I mean, it's again like coming back to the fact then, and as you said, like we have so many wonderful healthcare professionals in the system, and that can balance, and make these decisions. But in the end, it's also very, I guess, of course, it's part of the job, but I don't know if it's something we should call unfair that we put so much kind of responsibility on the health professional and in them making that decision. Of course, you need medical insight. You need to understand what does a patient need, what kind of treatment, how much value, etc. Like if I do this, will you live another 2 years or will you live another month, right? Of course that matters, like in a decision-making process. But sort of on the flip side, if we go to a system where, again, maybe where health insurance plays a much bigger role, where you have people who are covered and it's like just, spend as much money as you want, there's still ethical problems where, of course, people with less money cannot afford certain premiums, and then all of a sudden you cannot access certain treatments. And there's always going to be this, I guess, instability or, unfairness in what treatments you can't access or what you can pay for. But then you have this kind of middle ground where you always cover certain things. But it's when you get to these kind of edge cases, like, well, you have an 80-year-old person, they're admitted to a hospital, they have cancer, maybe stage 4 or something, they only have a few months left, and then the doctor makes the decision that we are not going to continue treatment. There's several factors, like, for example, will it cause more pain? Will it cause more suffering? Will it do this? But maybe in the perspective of the patient and their family, it's like, whatever you can do. And maybe the patient even wants to live longer. You want to try everything, right? Yeah. So again, this became a very, very long explanation for one simple question. Again, it's very kind of, it's very subjective on like how much is my life worth, right? To you. And then you have this, maybe the doctor, or maybe it's a policy or whatever it might be, kind of putting you, whether you want it or not, putting you into a category and sort of a prioritization system.
What I still like about our current system is that I think
Sweden
is that I think on the floor, so to speak, a doctor will think about his or her own oath and do whatever it takes when the patient is in front of him. And won't think about the clinical budget. At least I hope, and I haven't. In my experience, he or she doesn't do that. Once the patient is admitted, it's in there. You put the resources that you can behind him, whether it's an person who's got a very bad chance of surviving, or is an alcoholic maybe, or something, or somebody else. You you treat them the same way. And I think that's the right way to do it, right?
Yeah.
But when it comes to giving the annual budget to the clinic,
yeah,
you still have an indirect way of giving priority because you can only admit so many people. There are waiting times, etc. Right?
Exactly.
And you then get people are not responsible for finance who design treatment guidelines. And if you were to do everything according to the treatment guidelines by the different professional groups who do that, you probably have an explosion of costs in the healthcare system.
Yeah.
So in a way, I agree with you that, you're placing a lot of burden on the healthcare staff to manage within scarce resources.
Yeah.
Is that the right thing to do? No, probably not.
Yeah.
And it's becoming an increasingly big problem with so many new technologies and the infinite demand, and still a budget which grows at best by 2% per year.
Yeah, yeah, and it's well, I mean, again, like that's why this question is so sensitive, right? Mm-hmm. Because in the end, like or maybe you can answer this question. When you're looking at the policies and these decisions around healthcare and where you should spend money and what you should spend money on, isn't that, or I'm hoping at least, that a lot of these decisions are based on statistics and data, correct? Like in the outcome, or is it not? Like
I think when it comes to the health economic evaluations, if I go back to that, yes, I think they're very sound. A lot of meta-analysis and new studies when that's required, and very much by the book. And so when it comes to that, it is. But when it comes to my job as a CFO in a hospital, I never looked at these things.
No,
it becomes very mundane type of work, So in discussions with a head of a clinic, would be very much about, you're running a bit over your budget, how are you going to manage that, or that way. So far away from the health economic, maybe it's worth doing that because you need to, it's got a long-term positive effect.
Yeah.
That sort of discussion does not exist in an annual budget type of environment, which may be a bit sad to hear, but that's reality, because you get so slapped on your fingers if you don't stay within the annual budget, and even against the law for a now I'm talking Sweden again, county to overrun your tax financed budget.
Of course.
You don't have the mandate to do that.
Yeah. And I guess to a certain extent, that's a problem for I think most countries in one way or the other, because healthcare is, whether it is fully subsidized by government or not, it's always kind of a challenge in that regard. And you have a budget to work within. But if we try to summarize this, and then we're gonna talk about I guess just kind of a final thing before rounding off, is if in the end, I guess most people would want, like from healthcare, what you would want is that it just works and that it's there for you whenever you need it, right? And finances is always going to be a big part of it, because things are always going to cost money. It's never going to be free. Like money needs to come from somewhere, right? So in the end, if you're able to make, or it translate in one way or the other, each Cali, like the quality, like the translation there. So it's what is it? It's
quality adjusted life year.
Quality adjusted life years.
Yeah.
And this also takes into account the quality of the life years, right? That you're not just bedridden.
That's
example.
right. Yeah.
So essentially, if we can make each quality more cost efficient, that would hopefully now lead to I guess, more people being happy with the outcome of the services, correct?
Yeah,
in one way or the other.
Yeah.
That's how it would work.
Yes. Yeah.
So getting into the innovative future side, because this podcast is called the Go Beyond podcast. We like to explore what's beyond, the current system and the current infrastructure. How do we go beyond the traditional way of providing healthcare? Now, from a, not maybe purely, but from an economical standpoint, what do we need to do, or what's out there to make sure we have more cost-efficient qualities, right? And then we get to that point. Like, what do we need to look to?
I think we touched on many things already. I mean, the preventive care is one way of thinking about it, and not only preventive care, but to move downstream so that you do more self-monitoring.
Yes,
you do more in the primary care, and you avoid the expensive hospital care, and that's where I think technology becomes very important there, by having your diabetes apps or your way of monitoring your weight as a sign of for a heart failure patient to whether you get into the risk, or what have you. Those are the things which just need to be implemented on a much bigger scale than today, because most of the things are pretty well known and well studied, but at least our healthcare system here, and I think that's the case elsewhere too, you get it's very hard to scale up technology and make it be used all across very many different primary care units, or older people in their homes to have the staff who come and help them get their food at night, also have them, put their feet on the scale if they're heart failure risk patients and record it, to make every little thing in the healthcare system work, which is not so complicated once you do it once or monitor it, but having it to do it on a wider scale, that's the challenge. But if you can, but again, we've seen that with technology when it comes to our phones or whatever. When it becomes easy enough to do it, people do it.
They do it.
So I'm hopeful. Can you make easy enough things work for many people? You save a lot of resources and money as well.
This is a subject that's close to my heart, of course. But how do you think AI can make healthcare more cost efficient, and getting back to the qualities, right? And of course it's part of the apps and everything, but like, have you seen anything that's like, oh, that's interesting, like that? I think that'll help.
In my view, it's still a little early days, but but I think what you're doing, and when we were met a couple of years ago, before you'd gotten as far as you have now, just looking at the patient visit to primary care unit, how can you make that a shorter but better visit by way of the doctor already knowing, by way of your particular problem at the time, but also your risk factors.
Yeah,
I mean, so the decision making and the interaction there, which would help you in a more efficient, time-efficient way, prescribe whatever is needed to the patient, both way of preventative as well as curing care.
So you mean from like a triaging perspective? Knowing, investing into primary care, knowing what to do, where you need to go, care instance, decision making, and that way reducing the cost.
And also help patients do whatever they can themselves.
Yeah.
And instruct them to do that.
Yeah.
So you make it become less physician visits.
Yeah.
So that's on that side. When it comes to the hospitals, the Karolinska, right?
Yes.
And I think there is a lot to do on the prioritization of who should get what sort of care. So precision medicine, by way of diagnostics, being much more precise, who should get the expensive treatment and who should not.
Yeah.
And particularly the second question, who should not. So to dare, and also perhaps also dare not to perform the most advanced care on somebody who would lead a better life, higher quality.
Yeah.
By not being subject to a very painful cancer treatment or whatever at the end of their life.
And
so prioritization in the very expensive side of healthcare and helping preventive care and helping to self-monitor at the other end of the spectrum.
So I guess for my very last question then, before we wrap, for any, if you were to advise any policy decision makers in government, whatever it might be, in shaping the future of healthcare economics and making sure we have as many Callies as possible, again, such a wide subject, so many things we've touched on, like, well, what would be like the one thing that we would like, this is what you should think about from a health economics perspective in policy making?
Select the top 10 technologies that would really make a difference and make them and implement them as soon as you can. The givens, some technologies you can't make, but the accelerate the adoption of the technologies that could really make a difference.
Yeah.
And that might be selecting a big patient group like diabetes patients or whatever, make sure that every one of them do self-monitoring and cut their revisits to the primary care unit.
Yeah.
Not only pilot group, but every.
Yeah.
So that would be one thing. The other thing I would advise them to is to take the coordination between hospital and primary care and also home care seriously and manage it.
Yeah.
It's an unmanaged chain of care at the moment. And make it work, not only in some showcase examples, but across the board.
Mikael, it's been such a pleasure chatting with you. I wish I had another 2 hours to talk about healthcare economics, from Callies to the value of a statistical life, to what the costs are. This has been an amazing discussion. And really, thank you for coming on to the podcast, spending almost 2 hours with me. And really appreciate you coming on, Mikael.
Thank you so much. It's been one of the most interesting days in my professional life for a long time, just trying to chat about all these important things. So thank you.
Thank you so much.
And good luck.
Thank you. Thank you.